Good evening, dear colleagues. I would like to thank Dr. Iakovou for the kind invitation to participate at your great conference. Thank you. I will move on presenting the patient. 59-year-old female with a BMI of 31.5, history with fatigue and short of breath on minimal exertion, on for years, but worse in the last 6 months, NIHA 3. DCM on myositis background, MTR with 2 Pascal devices, CRTD, PAF, COAD, and hypothyroidism. We see on the right side the elevated hemodynamics. In the medical therapy, high volumes of diuretic therapy, and the labs, we see a normal creatinine and a BNP of 300 to 600. Tri-score 14%, Euroscore to 3.8%. This is the chest X-ray of the patient with the cardiomegaly. We see the proper position of the CRTD leads. The baseline transthoracic echo, we see the impressive tricuspid regurgitation with a TR radius of 1.1 centimeter, TR arrow of 0.52 square centimeters. Impressive is also the TR in the baseline transesophageal echo, and we see also that the RV lead could play a role in the mechanism of the regurgitation. ERO in the transesophageal echo 1.3 square centimeter R volume for 112 ml. In the coronary angiography, we don't see any significant stenosis, neither on the left nor on the right coronary system. So it was for us at Hygeia a heart team discussion. We took into consideration the option of optimal medical therapy, of surgery or interventional therapy, TR, or we could have also the option of TTVR. So we discussed about pros and cons, and we decided to treat this patient with TTVR. Why? We have a IACD lead involvement in the mechanism of the TR. We have a big arrow of 1.3 square centimeter, a large tricuspidal valve annulus of 45 millimeter. Of course, there are challenges for this patient. It is crucial to know if this lead is compatible. That's why we asked also for the opinion of our electrophysiologists. And we have the impaired RV and LV function, about 30% respectively. So the procedure, we see the Safari extra small wire in RV apex, steered by Agilis 8.5 French. It is really crucial for the TTVR, for the evoke implantation, to take time to place properly the wire freely in the RV apex, because it is really crucial for the delivery system, for the maneuvering. Here we see the delivery system of the evoke valve through TOE assessment in MPR. It is very important to adjust properly the position, the trajectory, and the depth of the valve. We shouldn't go too deep because we would interfere with a chordae, and we shouldn't stay too shallow because we wouldn't grasp the leaflets of the valve. So after the TOE assessment, and here we have to emphasize the crucial role of the interventional echocardiographer at this procedure. When we have the green light to proceed from the TOE specialist, then and only then we proceed. we expose the anchors to 45 degrees, and we have to say that from this point there is no return. We cannot extract the valve from this point, so we have to implantate the valve. We see on the right side the MPR. For each of the 9 anchors of the evoke valve, we check if the leaflets lie nicely on the anchor before we proceed. Next step is the anchors to 90 degrees and then flipped, always under strict TOE guidance. The next step is the ventricular expansion, full ventricular expansion, and then when we are all satisfied, then we release the valve. We see that the valve intervenes with the RV lead. So we have to say it's very important that the RV lead is not tensed before the implantation of the valve. And we see the TE assessment after release with elimination of the TR and no paravalvular leak. We see the nice images of the TOE. We see all 9 anchors of our evoke valve and no TR. So it was really unremarkable recovery. The patient was discharged on day 3. In the follow-up, 3 months NIHA improvement to 1 to 2, and 3 months free of cardiovascular events. This is the follow-up TTE. It remains a good outcome. And so, from our experience, from Dr. Spilias and our team, we try to summon selection criteria in order to be able to choose the suitable patient for TTR or for TTVR. So, from our initial experience, also with evoke, the criteria that could favor and would favor the TTVR therapy would be major coaptation gaps above 5 to 6 millimeters, lead involvement, the bicommissural TR, anterior and posterior septal, torrential TR plus large annulus and very wide VC. And on the other side, criteria that would favor the use of TR, would be the severe RV impairment, the severe PHT above 70 millimeters of mercury. Also, if the anticoagulation therapy would be strictly contraindicated. And of course, it remains to be answered which therapy would we use in terms of younger age and life expectancy. So the evoke valve, bovine pericardial leaflets, nitinol self-expanding frame, 9 ventricular anchors, and intraannular sealing skirt, available in dimensions 44, 48, and 52 millimeters. On the right side, we see the intraannular sealing skirt and frame of the valve. And as we said, the key procedural steps of the evoke system: access point, positioning, and deployment of the valve. It's a promising valve based on the TRISCEND 2 trial criteria, but of course, as we said before, we have to be very careful and choose the right patient for this therapy. Thank you for your attention.
Excellent case. So this is an exciting technology. Maybe it's not for everyone, but do you think it's how was the acceptance rate from the company when you are sending a CD to be evaluated by Edwards? What's your acceptance rate? Do you have like a kind of intrepid, like 30%, or it's 10% or less than the 10-dyne. So
thank you for the question, Dr. Iakovou. It's really to the point. Indeed, the acceptance rate, I would say it's much under 30%. I would say about 10%, since they're really concerned and eager to establish, to get this very good method, this gift for the patients established. So it is very important also to choose the right patient and achieve the right outcome for him.
But once you get in a position, maybe position is the most difficult to attain, right? Because you need to have a better trajectory, right? So
yes, that's very, very correct. Crucial, and they insist on it, is the placement of the wire. Is very, very important, because the maneuvering, the entrance of the delivery system is really demanding. So we have to be sure that the wire and the RV apex is really free. And so also is very important the dimension of the RA, so that we could maneuver and insert the RV. So, as you said, the exclusion of patient is really something very often.
good. George?
Well, excellent contribution on this very difficult, technically speaking, issue. From the clinical point of view, when you have an RV ejection fraction of 30% and you eliminate the tricuspid regurgitation, what is the expected outcome of the RV function?
Yes, until now, from our experience in the few months of follow-up, we see mainly improvement of the symptoms of the patient. We don't see objective outcomes concerning and referring to the RV ejection fraction. So also for us, and that's why we try to summon the criteria, it is indeed very difficult to choose patients for this method.
And another, again, clinical issue is, well, there is a notion about some cutoffs for the pulmonic hypertension, secondary pulmonary hypertension. Well, from our experience, if you have more than 50, 60 peak systolic pressure, it means that there is a severe left component, and the decompression of the RV is ameliorated by the TR. So it is difficult to accept that if you have a severe secondary pulmonary hypertension, the elimination of TR will improve the clinical status and the hemodynamics. It is something which cannot be accepted. So this notion, I think, has to be omitted.
Of course, I respect your opinion and I agree with it, and this is also the meaning of opinions exchange. We learn from each other, and of course we have to think and find the criteria, indeed, to choose the best for our patient. And if it is optimal medical therapy, then it is optimal medical therapy, as you said.
Yeah, so it's a patient selection, as always. Yeah, it's not easy to see which are the patients that they will have the biggest advantage of it after this procedure. As in every procedure, that's why it's important to discuss this case, all these cases in the heart team meeting. So thank you very much, Dr. Katsianos.
Thank you.
And the last but not least is Dr. Spilias. So last year,